Reed, and I'd like to welcome you to this morning's presentation, The Year of the Pandemic, Insights from the Front Lines. We had planned this webinar weeks ago and didn't realize how timely the presentation would be. But before we start, a few housekeeping items. First, we're recording this webinar. We will email all participants a link to the presentation in case you miss anything or if you want to send it to a colleague. Second, Kevin and Dr. Duffy, who we're going to introduce in a few moments, are going to take your questions at the end of the presentation. Please send any questions you might have in the chat box, and we'll do our best to get to them. And if we don't get to them all, we will get back to you. You should find that chat box. I think there's a question mark over by the dialog box. My colleague Debbie and I head up the healthcare team at Sachs LLP. Our more traditional accounting role has expanded to include helping our clients navigate their response to this pandemic. We couldn't think of a better way to understand where we've been and what the road forward is than to hear directly from the front lines. Debbie and I have the distinct honor of introducing two people that have not only been on the front lines, but have also been directing our state's response to this devastating pandemic. I'm going to start by introducing Kevin, and later in the presentation, Debbie will introduce Dr. Duffy. Kevin Slavin serves as President and Chief Executive Officer at St. Joseph's Health, an integrated, multi-hospital, major academic healthcare system based in Paterson, New Jersey. He is responsible for the overall strategic, clinical, academic, and operational functions of St. Joseph's Health, which encompasses not only the medical center in Paterson, but the Children's Hospital, the Wayne Medical Center, St. Joseph's Health and Rehabilitation Center, the Visiting Health Services of New Jersey, and numerous ambulatory and physician sites throughout New Jersey. Speaking of being on the front lines, I've had the privilege of serving on St. Joseph's Health Foundation Board. In this role, I've had a front row seat to witness the results-oriented executives bring industry leadership expertise and experience to the hospital. Kevin also serves as board chair for the New Jersey Hospital Association and has held a variety of legislative appointments to health boards, commissions, and other task forces. There's much more I can say about the amazing programs, such as Alternatives to Opioids program and the other innovations that Kevin has brought to St. Joseph's Health. But in the interest of time, let's jump into our program. And now, Kevin Slavin, our first presenter.
Good morning. Thank you, Sue. I want to start off by thanking you and everyone at Sachs for inviting Dr. Duffy and I to participate in this webinar about the COVID-19 pandemic, the first surge that we lived through, and what it feels like to be in what we call the second wave, which is happening as we speak. First, though, I just want to recognize the long relationship between Sachs and St. Joseph's, which goes back nearly 2 decades. Our partnership together has strengthened year over year. My own personal favorite event that we do together is the Sachs 4-miler, and as many of you know, over the past 9 years, this race has raised over $600,000 for the St. Joseph's Children's Hospital, particularly the Child Life Department, which provides the meets the non-medical needs of our sickest and most vulnerable patients. So it's partnerships like this that enable us to do the special things for our patients, and we really appreciate it. And the staff does as well. I'll talk about that, the great morale boost that these donations bring us. So I'm going to start off here highlighting one of our frontline heroes here on the first slide. That is Dr. Murad Ismail. He is the chief intensivist, chief of the intensive care program at St. Joseph's, which means he is the physician leader of all intensive care services 24/7 at St. Joseph's. And he has been on the front lines from day one and is instrumental in saving many lives, bringing many people through it, and leading the organization and helping others learn from our innovation. A little bit on St. Joseph's. We were founded 153 years ago by the Sisters of Charity of St. Elizabeth, religious order based here in New Jersey, who came to Paterson to serve the needs of the poor and most vulnerable in Paterson and the region. And we've continued to do that throughout our 153 years, now on a wider basis throughout the region. We're one of the largest health systems in the state. If you look at it by pure volume, we're the 5th busiest in terms of our overall activity. We are one of the safety net hospitals in the state, designated by the state, meaning we provide, along with 10 others, the bulk of free or charity care. That's part of our mission, and we're proud of that, and we continue to do that. We're also a major academic and teaching center, not just for physicians, but nurses, pharmacists, physical therapists, a really integrated approach, as well as being involved in research. So this is a great opportunity, this pandemic, for those learning in medicine to have a once-in-a-lifetime experience to get through this. And lastly, we're the largest employer in Passaic County with over 5,000 employees. So we have a large impact on the economics of the region, particularly in Patterson and Wayne. Going back in time, this certainly was the first pandemic that any of us in our careers lived through on this magnitude, but not new to St. Joseph's. As we say, this wasn't our first rodeo. That picture there is 1905, and you can see that's St. Joseph's and the nurses and the Mother Superior at the time taking care of patients on a ward there in the 1905 typhoid pandemic in this country. So you can see the other pandemics that St. Joseph's led through, and we took our inspiration from our Sisters of Charity, who are still working with us side by side during this. I'm going to now show a short video that really takes you through the whole pandemic, and then come back and conclude with a few slides, and then turn it over to Dr. Duffy. So Joe and I could certainly conclude the presentation today, move to questions after that, because that tells the story 100%. But we do want to take you through some more color commentary on things. I'll start from the state level. This year, I was elected as the chair of the Hospital Association's Board of Trustees, all of our hospitals. And in January, when I did my acceptance speech, I noted that we had a number of challenges ahead of the industry. And I was quite sure that there'd be one or two things that we didn't know about as we were convening then that would hit us hard. Didn't know that it would be this one. So we all took a turn in March. I was asked to join the governor's COVID-19 task force and spent many hours and days down there at what they call the ROC. That's the Emergency Preparedness Center outside Trenton, working with Commissioner of Health Persicelli, Kathy Bennett, who's the president of New Jersey Hospital Association. The commissioner then convened a professional advisory committee that I've served on, and Dr. Duffy has helped me with some aspects of that, looking at certain ventilators and drug allocations. And we've also organized the state into 3 regions to better coordinate care: northern, central, and south, because as the disease progressed, it certainly hit the north harder the first time around, progressed to the central, and then went to the south. We could talk about later, the current second wave is hitting the state equally, so it's not progressing from north to south. But these roles gave me some unique perspectives to share with you. So one of the things the Hospital Association did was quickly coordinate with the State Department of Health, Commissioner Persicelli, and work closely with her team to organize initially PPE. We were in dire shortages of PPE. There were major shipments coming from the federal government that eventually came, but they asked us, could you allocate that? Could you figure out how to allocate this? We don't have the bandwidth to do that. So literally over a weekend, Kathy Bennett convened her analytics team, her clinicians, got help from hospitals to advise, and we created a model, rudimentary at first, but that's been honed down, that looked at the burn rate of PPE, the number of patients you have, what your current supply is. So every time there was a new supply that came out of the federal stockpile, there would be an allocation that would be calculated for each hospital, and it would be delivered right there. So that was the first area of collaboration. Then we needed ventilators. So we were short of ventilators throughout the state. You probably remember that time. We were instrumental in working with the commissioner and her team so that they could appeal to President Trump and Vice President Pence at the time to get a supply of ventilators from the federal stockpile. And we were successful initially in getting about 40% of what we asked for. That was adequate at the time. What a lot of people are not aware of is that when those ventilators arrived at hospitals, many were in disrepair. Apparently, the federal government had let the preventive maintenance contract expire, so those ventilators in the storage down in Dearborn were not being kept up. So most of our biomedical departments had to, certainly inspect each one, but look for new parts, put them together, and they did. And there's a lot of innovation there from our collective biomedical teams. You saw the graphic there that we added 150 hospital beds. As the state advanced their predictive modeling, the commissioner said we're going to have to double the number of critical care and hospital beds in the state, look to move to what's called contingency staffing, which means it's still safe, but it's not ideal. And we all did. We put many, many spaces that we never thought could be put back into clinical use. Some were previous clinical spaces that were updated, but some were, teaching areas. I know in the case of Hackensack Meridian, they took a cafeteria and they turned it into a critical care area. Everybody did what they had to do, worked innovatively and quickly to do that. And we were able to meet that need. The state also put up field hospitals, not so successful because of the tremendous clinical needs of the patients. They really couldn't be cared for in those field hospitals. They really cared for patients that came out of the hospital, needed a place to stay for a day or two before they went home. A major issue, it sounds a little weird, but morgue overcapacity. At the height of the surge, we had tremendous mortality rates. The hospital morgues were overrun. The funeral directors were not able to get out and come collect deceased people. So we did a lot of things internally. There was one weekend I recall where it got to a point where I called former Governor Cody, who's state senator now, who's a funeral director himself. I said, Gov, we need some help here. Do you have any ideas? So he helped us work with the Murphy administration, the federal government, and refrigerated morgue trucks were sent from the federal government. They were leased. They were sent to, I think, Millstone outside Hightstown, and the hospitals were able to decant their morgues and treat people in a more dignified fashion than we were when we were over capacity. Dr. Duffy can speak to his key role at the state level when remdesivir was first available. We were one of the few hospitals in the state that was using remdesivir before this pandemic as part of our academic clinical trials. So this federal government did make a supply available to New Jersey, and much like they did with PPE and ventilators, they said to the state, here, we're going to send you all this supply of drug. You figure out which hospitals get them and you distribute it. So Dr. Duffy was part of a team that worked with the clinicians and epidemiologists at the state level to say, this is the allocation that should go to each hospital on an ongoing basis. And it's worked well. Now he'll be working on Regeneron, which is anticipated to be distributed again by the federal government to hospitals. That's the drug that President Trump and others have got that apparently works very well. So lots of different statewide coordination with state government and others. This is New Jersey at the peak, over 8,000 COVID-19 patients. We were able to meet that need in New Jersey. Originally, the projections were 13,000. That would have been touch and go if we had the capacity. Certainly those field hospitals would have been filled up, as well as a number of closed hospitals. At St. Joseph's, you'll see a slide in a second here, our peak was 456 COVID inpatients. So we went, you'll see on the slide, from 0 to 456 real quick. And at that day, at the peak, that was about 95% of our inpatients. 107 of those were on ventilators at our peak. That compares to the year before, non-COVID, to a typical day would be, at that period of time in April, would be 30 to 40. So significant strain on the system, but we're able to meet the need. This is what it looked like, and certainly felt, we were reminded how we felt when we had that upward surge. It came upon us so quick, that ski slope, that things had to be done in real time to meet the need. We went from 0 patients on March 6th to 456. That decline that St. Joseph saw that went through July was much slower. It was a much slower decline than other health systems saw in the state that were maybe as busy as us. Theirs was a ski slope down and then a very low level. And we're also now on the right seeing this second wave, which doesn't look like much, but we're getting there. Today we have 93 patients in-house that are diagnosed with COVID. Dr. Duffy can talk about their conditions. We had 3 weeks ago, we had 20. So we've gone from 20 to 93 in a short period of time. We see it as a staircase increase, not a ski slope. Still concerning. The good news is that number of between 90 and 93 is held over the past 5 days. So lots of patients are being discharged, but certainly lots of new patients are coming in every day. So New Jersey, you know the numbers, over 250,000 total cases, 1,500 hospitalized patients. St. Joseph's, those are our total cases. Many discharged home. We're very proud of that. And today 93. And certainly this second wave is upon us, and we want to reinforce with everybody what we need to do. So we'll do that at the end. So to conclude from my end, some key learnings from the leadership end. Certainly collaboration. We saw it in the hospital industry like never before. People who were competitors, head-to-head competitors, put that aside. Everybody did what we had to do to help each other get through this. There was great collaboration that I mentioned with state government, but also within the industry, with the hospital association, being thrust into a role that it never was in before to really organize the care and cooperation. System to system, the 3 large systems in the northern part of the state worked with St. Joseph's on key learnings. We shared that with the rest of the industry. But things went from, I have a story on a particular Saturday, Central State Medical Center in Freehold put a call out. They're out of gowns. They were out of gowns. The central part of the region where things were coordinated could not help them. So one of the hospitals in the north stepped up. I think it was Englewood Hospital, sent a shipment down to John Gribben down there, got him through the weekend. So those are the kind of things that were done. We all put our competitive things aside and focused on what we could do to help each other so we could serve the residents of New Jersey. Certainly innovation was at all levels, from all corners. St. Joseph's has a unique innovation approach. We don't do it in a Shark Tank approach. We've set up an innovation center. We're funded through the Nicholson Foundation to learn innovation techniques, micro sprint, human-centered design, things like that, and push that out to the entire organization. So our teams use that. Things were done in real time. For example, the lab testing that you saw there, that was a huge breakthrough for St. Joseph's. Early in the pandemic, it was not uncommon to wait 3, then 5, then 7, and sometimes 10 days for test results to come back on COVID tests. That meant that patients had to be isolated. Everybody had to wear all the protective PPE, don and doff each time. By doing that, that cut our response time to those tests from days to hours, to about 4 or 5 hours. So our lab was instrumental in getting approval, FDA approval with Becton Dickinson. We bought additional technology, and then we were faced with not enough reagents to run the tests, running out of reagents. There was a national shortage. One of our employees, our microbiology manager, Nina Fernandez, who ran that whole unit, she was actually home sick, positive, and did research on her own while she was home, and she found out how we could manufacture our own reagent materials. We got approval from the FDA over a week period of time, so we began to produce our own reagents rather than relying on outside suppliers. Things like this were done all over the organization. I remember being Easter Sunday, making rounds for the team and going up to Wayne, the Wayne campus, and they were in the midst of turning the recovery room into an intensive care unit. Lots and lots of hands on deck for that, and I was fascinated by our director of engineering and maintenance telling us all the different things he had to do with the airflow to make sure that we had the proper pressurization and airflow in that new space so that other areas like the operating room, which was adjacent, would not be contaminated. Lots of intricacies because of the way the building was built, and wings were added on. So the engineering and maintenance areas in hospitals were really part of this whole innovation effort. And then lastly, people, the resilience of the people. Certainly here at St. Joseph's, that's always been our strength. You know, from a leadership perspective, you saw many people, most I would say, step up and perform at unheard of levels. We saw new stars arise, people that emerged that you hadn't seen before in these roles. And from a leadership perspective, you saw some people that faded. They had some valid reasons that they did not want to participate at that time, maybe health issues, some things at home, but there were also some folks that really just couldn't operate from a leadership perspective in this intense period of innovation and speed and things like that. So one thing I learned is the benefit of, and we've revisited, a succession plan. We've begun doing succession planning at St. Joseph's at the leadership level. We're now moving it through the middle management level, because you saw that Dr. Pruden, and you all know that story, that Jim Pruden was one of the first patients that was exposed. He was our director of emergency preparedness, so it's a tough position to lose. But also at that period of time, probably about half of our emergency preparedness team and infection control department were sidelined because they were exposed. So different people had to step into different roles. Leaders like myself, I said, had to do actually some real work during this pandemic and step in and help wherever we needed to help. So the need for a succession plan was critical, and we're continuing to work on that. And just lastly, the donations we received from many of you in the community, whether it be PPE, food, whatever it was, meant so much. Not just the donation itself, but the expression of support. I can't tell you what a morale booster it was to the different staff, the departments, because we would rotate each day which department would get a food donation for lunch or dinner, and they'd come down to the lobby and they'd take pictures and they would get excited, and it just helped in many ways that you could not imagine. So again, I want to thank you for that. I will be back after Dr. Duffy's presentation to certainly answer any questions. So I'm going to turn it over to Dr. Joe Duffy, who's our Senior Vice President and Chief Medical Officer.
Kevin, thank you. Just really want to thank you for your presentation, for your leadership. So moving to see all the components and what St. Joseph's has done during this time. Good morning. My name is Debbie Nappy, and as Susan Reed had mentioned, I also co-lead our healthcare industry group. And this morning, I have the distinct pleasure of introducing Dr. Joseph Duffy, the Chief Medical Officer for St. Joseph's Health. Dr. Duffy was born at what was then St. Joseph's Hospital in Paterson, and he was raised in Paterson as well as Wayne. After completing his education, he received a presidential appointment to the United States Air Force, and upon completion of additional training, he became an operational flight surgeon, achieving the rank of major. He participated with special operations in North Africa, the Persian Gulf, Somalia, and Bosnia. Today, Dr. Duffy has served as a member of the St. Joseph Health Board of Trustees, the Vice President of the medical staff. He also has served on the State of New Jersey Department of Health Advisory Committees and the Family Medicine Section Chief for St. Joseph's Wayne Medical Center. He serves on multiple committees for St. Joseph's Health and co-chairs the St. Joseph's Health Accountable Care Organization, while also maintaining a medical practice in Wayne. Dr. Duffy is board certified in family medicine, hospice, and palliative care medicine. I will now turn the presentation over to Dr. Duffy. Welcome and thank you.
Thank you, Deborah, and welcome everyone, and thank you for tuning in. This morning, we're going to talk about what we've learned and what lies ahead with the coronavirus epidemic. Next slide, please. So what we do know now is that there's a wide range of symptoms from mild to quite severe. And unfortunately, it leaves many of us in a quandary when we wake up in the morning with a sore throat or a headache, asking ourselves if we're getting into trouble. Symptoms such as fever, body aches, sore throat, dry cough, diarrhea, all very common and all overlapping with what's known as influenza-like illness, or actually the flu. What's very paramount to the diagnosis and almost clinches the diagnosis for many of us as clinicians is the loss of taste and smell. We often advise people that if you have these mild respiratory complaints, wait a day or two before you run into work and see what's going to happen. What's interesting to note is that the majority of people do recover without requiring any special treatment at all. Unfortunately, older people and people with underlying medical problems are more likely to develop a more serious case. Unfortunately, what we've also uncovered is that the spread during our younger people population, throughout that population, vaping and close behavior with lack of social distancing has propagated this spread. Next one. So we've probably all heard by now with President Trump, remdesivir. Remdesivir is an antiviral drug, but it's not the only medication in our armament against this beast. We now use high-dose steroids, high-flow oxygen, anticoagulation, which is known as blood thinning. We use convalescent plasma, which was initially established by the Mayo Clinic, and St. Joseph's did participate in the preliminary research of this and remdesivir. We also give quite basic immune support with vitamin C and zinc. But more important than all of this is the knowledge of what works and what doesn't. So we all heard about hydroxychloroquine in the very early phases of the epidemic. We now know that's completely off the table, as is certain other medications which were constantly put on the forefront, such as ivermectin, strangely enough, an anti-parasitic drug, which is no longer considered. What's on the forefront in the next months will be monoclonal antibodies. Regeneron has now increased their production of their monoclonal antibody. And just yesterday, Eli Lilly announced the availability of yet another antibody drug, which will be available quite soon. Next slide. So what's very interesting and on the forefront also is the COVID-19 vaccine. As you may have heard, Pfizer has readied itself to be on the forefront of production. It's also interesting to note that Pfizer was ready in September with this vaccine. It was very confident that it would be available, and they were so confident that they actually produced the drug, the actual vaccine, ahead of schedule, and is currently now stockpiling this. And also what they've done is they've actually developed their own patented cold box transportation system. We've all heard about how difficult this vaccine is to transport. It requires temperatures of -75 to -85 degrees Fahrenheit in what we term cold chain custody, where we cannot have any breaks in the temperature. Pfizer has gone ahead, developed a cold box with dry ice, which can be transported throughout the United States and actually its territories. They're actually working right now with Puerto Rico to ship the drug there under cold storage boxes so it can be distributed through the Virgin Islands, just to explain some of the complexities. Of course, when this vaccine is available, and close on its heels is the Moderna vaccine, which is very similar, there'll be a limited supply. We've established in the state of New Jersey, and Kevin has worked extensively with the vaccine allocation committee, and they have determined social determinants known as the social vulnerability index, which allows us to determine what individuals will be most benefited by the allocation of the vaccine. Next, please. So these are 5 basic steps that Dr. Fauci has recommended, and it still holds true from months ago. First of all, wear a mask. It's not a political statement. It's a life-surviving measure. Maintain social distance, 6 feet. Avoid crowds. More people, more exposure means more COVID. Of course, outdoors is better than indoors. And even after you've been anywhere, maintain hand hygiene with alcohol, wipes, and hand washing. Next slide, please. So I'd like to conclude with the words of Jim Pruden, my colleague, who we fought so hard for to save his life. As he stated to 60 Minutes, I got admitted to our own hospital. I'm the luckiest man on earth to be in a hospital where people are geared to do this, keep people alive. Thank you.
Well, I can't thank both Kevin and Dr. Duffy enough. I'm so sorry, I hear a little feedback on my phone here, but we can't thank you enough for the insights that you have today. As I mentioned, we would like the participants to ask questions, so please feel free to put any questions you might have into the question box. I'd like to start our questions off, if I could, by asking Kevin a question. Given the rise in the new cases, how will the second surge be approached differently, and are you doing anything different to prepare this time?
Sure. Yeah, we never stopped preparing after, took a little bit of a pause perhaps after that massive surge, but always did what we call hot washes and emergency preparedness, post-incident reviews. So we were reviewing what worked, what didn't, getting ready, tuning up our plan for the next time. It was always we were always reminded by the Commissioner of Health that there was anticipated to be a second wave in the fall, and she was right, unfortunately. So we've been preparing, creating playbooks, getting ready. We feel really good about where we are. Certainly, all the hospitals were required to not just have additional PPE on hand, but also stockpile. We have a 90-day supply in a warehouse, undisclosed warehouse, I'll say, that's there just in case, in addition to what we have in-house, and every hospital is required to do that. We're in much better shape with ventilators. We can open up beds. So we're in good shape. I would say great shape. The only concern we have is if we do get a significant surge anywhere close to before, staffing will be an issue for New Jersey hospitals, because we were helped tremendously by nurses and others coming from other states. We, in particular, the Catholic hospitals had nurses come from Centura Health in Denver, Colorado, where a friend of mine is the leader. He had excess staff. He put them on a plane, sent them 40 nurses to help us as we were coming out of that surge. That's not available anymore. We also had nurses coming through agencies from all parts of the country, Alaska, you name it. With the country on fire, as we've heard, we're not going to have that extra staff available. So we're concerned about things.
Thank you.
Dr. Duffy, this question is for you. And actually, I'm going to combine it with a question that's just coming into our chat box. So the question was, with the experience that you gained from the first surge and with the innovation in treatments, how do you feel that incoming patients will fare? And the question that also just came in is, based upon what you just mentioned with vitamin C and zinc and blood thinners as supportive treatment, should we be taking these supplements on a daily basis to sort of protect our bodies from this virus?
Very timely questions, Deborah. So the first part of the question I'll answer with this. It was about 3 to 4 days ago that they actually released a combination of 2 studies, one done in the UK and one done in the United States in New York City, which actually demonstrated that you were 3 times as likely to die if you came into the hospital in March as in August. So we have learned how to treat this a little bit better than what we first had at our disposal in March. We know what works and what doesn't. We're always looking towards the latest protocols. Last night, I was on a webinar at Massachusetts General Hospital, Harvard Med, to get the latest insights as far as their treatment protocols. And that's what our staff does. When they go home at night, they don't put on Jeopardy or Wheel of Fortune, they research. And that's what they're all about. In terms of immune support, I could only recommend that all individuals should check with their own physicians in terms of what they should be taking as a supplement. But zinc and vitamin C has been put forward as an immune support. So if you think that that may be an option for you, I would always suggest that you check first with your primary care provider to see if that is indeed an option.
Thank you.
And Kevin, in your role as the board chair for the Hospital Association, I want to ask a question that a couple people are alluding to here in regard to a vaccine, you know, in regard to a timeline for distribution. And do you think only one vaccine is going to be distributed by the FDA, or could they both wind up being distributed, you know, really increasing the quantity of vaccines that would be out there?
Great question. I think that depends on, you know, when Dr. Duffy can elaborate, they will both apply or more perhaps for what's called an emergency use authorization from the CDC. If they grant that, it will then go to another body, the American College of Immunization Professionals, who's an independent body of scientists and medical professional and ethicists who will look at it. They'll weigh in, and then it will be allowed for distribution. We have been asked, the hospital industry has been asked to prepare for two scenarios. One, that there's a very limited supply at first in late December, early January. That might be moved up now with the Pfizer news. And that would be very limited, and the focus would be initially on frontline medical and first responders, EMS, police, hospital employees first, those that take care of those that have COVID. Right. Followed then by essential workers in other industries and long-term care. There's another scenario that was mentioned last week that perhaps planned for a more ample supply to follow. So we're being, and with that role, the hospitals have asked, we've been asked the question as of Friday, would you be prepared to be the central distributor in your communities for vaccines to not just your own employees and those but others? And the answer is yes, we would be prepared. We're not prepared today, though. We'll be prepared for our own employees, but we'd have to ramp up certainly to be able to be a regional distribution center. I think one of the things that, and Joe, you can elaborate, surveys show that well over 50%, in some areas over 60% of the American public have said they are not going to take the vaccine for some time until they see that it's effective.
Yes, and that's a very large concern for the federal government. As a matter of fact, the Commissioner of Health alluded to on Sunday, where she appeared on 60 Minutes, that approximately 40% of the state's nursing staff and 60% of the state's physicians, when polled, indicated they would be willing to take the vaccine. Now, of course, the problem is nobody knows what particular vaccine will be put forth. There are different types of vaccine. So currently, the Pfizer and Moderna vaccine operate on what is known as a messenger RNA platform. The J&J vaccine is a vector vaccine which utilizes a virus that has to be injected into the body in order for it to deliver the protein for antibodies. So the advantages, J&J vaccine is a single dose vaccine. The Moderna vaccine and the Pfizer vaccine require 2 separate doses, 28 days apart. That also keeps the state and the federal government awake at night, because unless you receive both doses of the vaccine, receiving a single dose is just totally useless. So these are all big concerns for all of us.
And Dr. Duffy, to that point, then when do you think we would feel the impact when the vaccine is widely distributed? Do we have any timeline as to when the public would just feel the impact of getting past this virus?
No one's quite sure. There's various predictive models. I think I said it best to my son sitting across the dinner table when he came home from college. He said to me, "When are we going to get rid of these damn masks?" And I said, "Be prepared to wear it for 2 years." So I think it'll be well to the end of 2021 that we'll still be wearing masks until we get what is known as herd immunity. So 70% of the population has to have antibodies before we can stop the spread of this thing. So it's a tremendous lift. So couple that with people who are unwilling to get the vaccine and people who think that once they've had the virus, they have antibodies for life. they don't. They often drop off after 3 to 4 months. These are major concerns. So well past 2021.
Kevin, as I had mentioned to you, we have a lot of clients at SACS that work in the healthcare industry, many physician groups that we work with. Do you have any advice to those in the medical community on, what you see the road ahead being?
I would just say prepare as best you can, particularly for physicians, apply for as much of the supplemental funding that's available. I know we were asked by the commissioner's team, could we help get the word out to the physician community that there are federal funds available, because many did not avail themselves of that. Don't hesitate to work with your affiliated hospital if they are affiliated with a hospital. I was with one of our largest primary care physicians last night in his office, and it was just fascinating. They got ahead of it early on. They have, like many others, jumped into telemedicine and made that work. They have made the wise decision to keep that up. Once their doors opened back up again, they didn't turn off telemedicine and turn back on in-office visits. They have kept both going, and they're seeing a rise in their revenue, actually, because of that.
Great.
Dr. Duffy, I have a question that came in through the chat box. The question is, what is your recommendation to someone who has the virus, is not required to be hospitalized, but how should they be caring for themselves at home?
Probably first and foremost is adequate support of wellness, which means eating well, sleeping, and giving yourself immune support, such as the vitamin C and zinc, if you can medically be able to take that. Self-monitoring is great, but you probably should check in with a healthcare provider. And as Kevin indicated, telehealth is a fantastic option for doing such. Sometimes we can see subtle things in individuals that they can't see in themselves. For instance, over the weekend, one of our radiology technicians became ill, didn't think much of it, and our director of radiology noticed he just didn't look right, told him go home and get tested, and sure enough, he was COVID positive. Even after that, he couldn't believe he was COVID. And thank God he didn't expose any patients because he was wearing a mask. He didn't go into the work environment. But I think it's a very important aspect of not trying to push yourself, just like you would if you had influenza. Same criteria applies. Tylenol, rest, fluids.
Great, thank you. And actually, I'd like to ask a question to really get both of your perspectives on it. We have the holidays approaching. Thanksgiving is going to be here in 2 weeks. What are your recommendations for getting together with family and, how to handle the holidays?
Well, personally, I and my family are going to follow the advice of the man in the white coat. So I'm going to let him tell you what his recommendation is.
Great.
Personally and professionally, I would not extend family invitations out to wider groups. I would keep it within the confines of the people that you live with. What we're trying to foster both in the community and also within our hospital, which has many young people who work here, nurses and resident doctors, we try to tell them to keep to their pods, people that they associate with socially all the time. Once you bring people into the mix, people that you don't normally associate, the risk automatically goes much higher. Coupled with that is the major concern of young adults returning home from college. College is a major spreader event in many university settings. And unfortunately, when they do come home, they may not even be symptomatic and may spread it to older adults. So that is the major concern. So smaller groups, family, not extended family, best option.
Yeah,
Thank
I
you.
would just add here at St. Joseph's, given the experience of the last 3 or 4 weeks, we've put back into place some things that we had in place, like people that had been working from home, some had come back on site. We're now pushing back to, if you can work from home, work from home.
Mm.
We're taking a serious look at all break rooms, lunch rooms, and probably going to restrict those significantly.
Dr. Duffy, would you even recommend for the college students coming home that they be tested before they do, given the fact that many do visit their grandparents or elderly, relatives?
Yes, it's a very good option, but I would also recommend not visiting elderly relatives, period. It's just too much of an unknown. And the reason I say that is oftentimes people come and they get tested and then they develop symptoms while they're visiting 3 and 4 days later where the test doesn't pick up the virus. And that's a very characteristic finding of community spread. It spreads very easily. I wouldn't fault being tested. Probably the biggest rate limiting step right now is finding a place to get tested. St. Joe's is one of the leaders in community testing. We have a grant for regional testing. Just to give you an idea, yesterday at about 3 o'clock in the afternoon, we had to shut down the line for drive-through because it was so far deep. It was almost a quarter-mile long. So that's not unique to St. Joe's. You'll find that in any walk-in medical center, urgent care center, or any other testing site. You're going to see a surplus of people and not enough hours to be tested.
Kevin, as far as the rise in the rates of COVID cases, Governor Murphy has certainly put some additional restrictions in. Do you feel those restrictions are enough to help temper or curb the curve from going back up again?
It's a great question. We'll see. I'm not sure about that. I know some of those were based upon, a lot of it, most of it was based upon the contact tracing, where they can trace back to where the outbreaks were. Certainly bars late at night. And there's also observations made by law enforcement. I know here at Patterson, as they had to respond to certain events at different social clubs or bars or restaurants, they were pretty shocked about what they saw when they walked in. Interesting, today you saw that some restaurants are saying they're positive on it and some are outraged by it. I expected more, to be honest with you. I expected more restrictions, so I think he was pretty liberal so far. I haven't heard this in any of the meetings I've been in, but I've been asked by a number of people, do you hear that we're going to have a shutdown between Thanksgiving and the first of the year? Haven't heard that, but that's certainly a rumor out there. I think it'll be interesting to see what, I guess we could call him President-elect Biden's new commission, if they come up with anything soon in terms of their recommendations.
Yeah, true.
Dr. Duffy, I have one last question that has come in. The question is, if someone has recovered from the virus, could they still transmit it? And what level of immunity do they truly have?
Excellent question. So if you have recovered from the virus, we generally know that 10 days from the onset of symptoms, viral shed, meaning the virus coming out of your body, is significantly less to basically almost non-transmittable. Unfortunately, there has been one case demonstrated of an individual who transmitted the virus for 70 days because she was immunocompromised. She had cancer and the virus just lived in her body. So we don't know who those individuals are, if they're exposed, if they have issues with their immune system, that they may be carrying that virus. So generally 10 days for a healthy person is considered a safe cutoff. And of course, it depends on whether there's symptoms. So we generally go with 3 days of no symptoms and no fever without fever reducers as another qualifier. Antibody testing, currently probably worthless. We know now that we can't quantify antibodies. Not only can we not quantify antibodies, we now know that they oftentimes drop off after 3 to 4 months. So there has been no demonstrated long lasting antibodies from the first go around of this virus. And in some countries, some people are becoming reinfected, Italy as an example. So wear a mask.
Thank you.
For quite some time. If I could just ask you to advance to the next slide. On this slide, you'll actually see our contact information. We tried to get to as many questions as we could, but certainly if there are additional questions, please feel free to contact us. I think if there's just one more slide, we'd also, as Kevin mentioned, SACS has a terrific relationship with St. Joseph's Hospital. As you can hear, the hospital does amazing things. One of the biggest employers in the state, really does work to not only, take care of people in the hospital, but also in the community surrounding them. So we'd like to encourage everybody to, reach out. And actually, I think we have one more slide. I'm sorry, if you could just go forward one more. We have a give to stjosephs.org link on our presentation. We'd really appreciate it if you consider making a donation to help Kevin and the people at St. Joseph's continue to fight the good fight. We're going to have a tough year in 2021, lots of changes happening, but I think if we all stick together and work as a community, we'll get through this and hopefully be able to burn our masks at the end of 2021. Well, thanks so much, and I hope everybody has a great day.
Thank you. Stay safe, stay well.
Thank you.